Well, good afternoon, everyone. It's fantastic you've been able to join us for this presentation. My name is Andrew Watkins, and I'm the Director of Programs and Innovation for Mindgardens Neuroscience Network. I'm a mental health nurse practitioner by background, and it's fantastic to have you all here, and I'm pleased to be here to chair today's webinar. Firstly, I'd just like to start off with an acknowledgement of country and lived experience. So I would like to acknowledge the strength and resilience of Aboriginal and Torres Strait Islander people who are the traditional custodians of the diverse countries from which we are joining this meeting. I myself today am privileged to be calling from Gubbi Gubbi country, and I pay my respects to elders past, present, and extend that respect to all Aboriginal and Torres Strait Islanders people that are present today. I would also like to acknowledge people with lived experience of mental ill health and recovery, and the experiences of people who have been carers, families, and supporters. The Mindgardens Psychosis Webinar Series is part of the Mindgardens Tertiary Referral Service for Psychosis, or TRSP. Now, TRSP, for anyone who might not be aware, is a statewide service funded by New South Wales Health and hosted by South East Sydney Local Health District. And Mindgardens is very grateful to both CESLED and New South Wales Health for their ongoing support of TRSP. TRSP for psychosis aims to improve the lives of people living with complex psychosis. It does so through the delivery of a clinical service which welcomes referrals across New South Wales of anyone living with psychosis and receiving care from public mental health services. It also runs education and training programs such as the one we've got today to help build capacity in caring for people living with complex psychosis. This webinar series is supported by Mindgardens Neuroscience Network. And for those who may be unfamiliar with us, Mindgardens is a partnership between our founding members, Neuroscience Research Australia, or NEURA, the Black Dog Institute, UNSW Sydney, and South East Sydney Local Health District. Mindgardens was established in 2019 to enhance collaboration between the members, bringing together clinicians, researchers, health service administrators, and people with lived experience to design research and quality improvement projects that can be translated into everyday practice, matching consumers' priorities and making a real difference in people's lives. The Psychosis webinar series will run throughout 2025 on a monthly basis. So please look out for emails from Mindgardens with future details of webinars. And the idea is to tailor for all clinicians. We will have a QR link at the end of today's presentation that you can get to the Mindgardens event page, and our team might also put that in the chat or Q&A box as well, if possible, so that people can grab a link to see what is happening. A little bit of housekeeping for the rest of the webinar. You would have seen a couple of poll questions that have gone up during my introduction, and there'll be a couple more at the end. We would really appreciate if you could answer those. Your answers will be anonymous, and what therefore is to help us constantly improve these webinars and so that they can meet the needs that you guys have. There will be a Q&A session at the end, so please add any questions into the chat window during or after the presentation, and we'll endeavour to answer as many questions as possible. We'd also appreciate your feedback by email. So if your question isn't answered or you'd like to share any suggestions for future webinar topics, please email us at contact@mindgardens.org.au. We'll put that email address in the chat as well. We're recording this webinar and it's going to be distributed to all registered attendees within a couple of weeks, so keep an eye out for that. Our speaker has also kindly agreed to share the slides today as well. So finally, it's my great pleasure to introduce Professor Kimberlie Dean, who's Head of Discipline of Psychiatry and Mental Health at the University of New South Wales. Kimberlie was appointed to the inaugural chair in Forensic Mental Health at UNSW in 2011, a joint appointment with Justice Health New South Wales. She also holds a clinical academic position as a Consultant Forensic Psychiatrist with Justice Health New South Wales and is Academic Program Director for the Masters Forensic Mental Health at UNSW. Kimberlie's research includes understanding links between mental illness and offending behaviour, including violence, and testing interventions in justice settings and populations. Please join me in welcoming Professor Kimberlie Dean, presenting Understanding Forensic Mental Health, the intersection between psychosis and the justice system. I'll hand over to you now, Kimberlie. Thanks very much.
Thanks very much, Andrew, and thanks everyone for joining. I'll get started straight away. I know we don't have a lot of time and it's a big topic. I would like, though, to begin by adding my acknowledgements to the traditional custodians of the lands we're all dialing in from. And in the context of this presentation, I want to also particularly acknowledge the over-incarceration of our First Nations people in Australia, and I will come back to that topic during the presentation. So understanding forensic mental health, the intersection of psychosis and the justice system, it is a big topic, and I'm only going to cover the sort of basics and the surface level to some extent in our time today. But if people have any questions that I haven't covered, feel free to ask them or to contact me afterwards. These are the topics I'm hoping to talk about. Firstly, I'm going to take a population epidemiological approach to much of the talk today. So thinking about whether there is an association between psychosis and risk of violence, offending, criminal justice contact or not, what we know about that association locally in New South Wales. Have there been changes over time, and what do we understand about this association for subgroups? I want to talk a little bit about the transition for people into and out of custody, really important points of vulnerability for people coming in and then leaving custody. Just want to touch on this very complex issue of what really causes the association between psychosis and those risks. Talk a bit about differences between men and women and how things might differ over the course of a psychotic illness. Ask the very important question, which is not really well answered, is does treatment for psychosis help to reduce the risk? And then I just want to mention a bit about forensic patients, which I'm not going to focus on, but are obviously an important subgroup amongst those with psychosis in contact with the justice system. And finally, just to remind people that the risks are not only in terms of perpetration or offending, but also in terms of people with psychosis being at increased risk of experiencing crime and violence as victims. So a lot to cover. And apologies if it's at a not fully detailed level. So firstly, this is the central question of forensic psychiatry and forensic mental health. The association between mental illness, particularly severe mental illnesses like psychosis, and whether or not there's an increased risk of all sorts of things related to the justice system, of violent behaviour itself, of criminal behaviour, and of criminal justice contact. And those, I'm putting those things together, but they aren't the same, and there's all sorts of reasons why they are quite distinct, but often combined, really. And the evidence for the association of an increased risk is quite strong now over several decades of research, with 3 different types of studies contributing to that evidence. The first is that we have a lot of studies based in prison or other offender settings where the prevalence of mental illness is much higher than you'd find in the community. We then have a lot of studies where the population or the sample is a clinical sample, so it's a sample of people with severe mental illness, and then researchers have looked at how often offending behaviour or contact with the justice system occurs, and it's higher than you would expect in other samples. And then finally, there are unselected population-based studies, such as general population surveys, birth cohorts, and data linkage studies that have also confirmed this association between mental illness, particularly psychosis, and risk of violence, crime, or criminal justice contact. So it's a very consistent statistical association in research terms. And just to give you an example, this is now over a decade old, this review, but it does include over 100 prison samples that have been published, and the rates of psychosis in those studies were pooled and had a pooled average of 3.6% for men and 3.9% for women, which is, of course, much higher than the prevalence of psychosis that you would find in the general population. And then as an example of that second type of study where looking at the association between psychosis and violence, another systematic review, and this is a forest plot from that systematic review by Fazell et al., where they divide the studies up into the top group are those with a sample of men, the second group are mixed gender, and the third group are studies with a specific sample of women. And all the results to the right of the vertical line are significant, showing a significant association between psychosis and violence. And then those diamonds show you the kind of pooled or averaged amount, so you can see that they are well in above 1. And interestingly, and we'll come back to this, the pooled estimates for women in terms of how strong the association is between violence and psychosis is higher for women than it is for men. We also looked at studies examining this question, but broadened it beyond violence to think about any kind of offending. And we found similarly that there was an association across the studies. This is a forest plot again. The pooled odds ratio was 2.65 for the sample, so that people with psychosis, their odds of any offending was 2.65 times that of people without psychosis. We also found higher odds ratios for women, but the difference wasn't significant. And a lot of variation between studies in this review. So you can see one of the things that's interesting is that the association is not as strong for any offending broadly conceptualized than it is for violence more specifically. Then a more recent narrative review looked at all of the research to date on this question of whether there's an association between psychosis and violence and offending. And this is a conclusion from that review in 2021, that relative risks are typically increased for all violent outcomes in most diagnosed psychiatric disorders. And we'll come back to this point. It's not only psychosis where we see this increased risk of justice contact for violence and offending, but it is particularly high, as this paper I highlighted, amongst people who have a diagnosis of a personality disorder, a psychotic illness, and even higher for those with substance use problems. And we'll come back to that as well. So what about locally? This is a study reviewing all of the prison surveys in Australia and New Zealand over a long period. So 17 studies were identified in this review that Natalia Yee, one of my postdoc researchers at Justice Health, conducted. Over 10,000 people in prison in the pooled study. And the prevalence of any mental illness was almost 70%, and the pooled lifetime prevalence for psychosis was just over 9%, which is actually higher than that international systematic review I showed you at the beginning, and obviously much higher than you find in the general population, where prevalence of psychosis is less than 1% typically. We also looked at current illness where it was reported. Just over 50% of people in prison during all of these surveys reported current mental illness, and the rate of current psychosis was also very high, 6.4%. And because we took studies over a long period, over 5 decades, we also looked at changes over time, and I'll come back to this point. We did find in this systematic review some evidence that rates of psychosis amongst people in prison had been increasing in Australia over time. The other information we have locally in terms of the intersection between psychosis and the justice system is the surveys that have been conducted in New South Wales. And we looked at 3 surveys from 2001 to the last one conducted in New South Wales in 2015. And self-reported psychosis did appear to be increasing in New South Wales prisoners over time as well. So in 2001, 4.3% of people surveyed in the prison health survey reported psychosis, and in 2015 the rate was just over 10%. So really very high rates. Now, I mentioned that I wanted to talk a little bit about the periods of transition into and on release from prison. One of the things we do in justice settings that's really important is that we screen people for all sorts of health problems as they're coming into or shortly after they arrive in custody. There are not really many other circumstances you could think of where a whole population receives health screening like this. Comprehensive. It's not detailed, there's not the time for that, but it covers the whole range of physical health and mental health problems. And we've been doing a lot of work in New South Wales, a lot of research focused on that screening, how to do it as well as we can to try and identify people in greatest need so that they can receive treatment and or be diverted away from the justice system where that's possible. So this data comes from a study several years ago now, where we recruited people from reception or shortly after reception into prison. We had 112 women in the end and 230 men from the reception centres at Silverwater in Sydney. And we looked at their profiles, their sociodemographic profiles. You can see there around a quarter were First Nations, self-identified as First Nations people. And that rate actually for prisons in New South Wales now has gone up to closer to a third of male prisoners, and it's around a half of female prisoners are First Nations people. But you can see there significant rates of mental health problems are reported. And we found at screening that over 60% of people reported ever having experienced any psychotic symptoms, so incredibly high rate. And that's something I really wanted to highlight. In these prison surveys that I mentioned before, where we do see high rates in the region of 5 to 10% lifetime prevalence of psychosis, those are typically random samples of inmate populations. And actually, when you look at people coming into prison, their levels of morbidity are much higher. So these prison surveys, which are random samples of people incarcerated, actually underestimate the levels of mental ill health because a lot of people coming into custody are there for such short periods. They might be released within days or have very short sentences or are only on remand. And so they never make it into a random survey of an incarcerated population. But those people coming in for often short periods have particularly high levels of morbidity, and we find that on our screening studies. We published this paper from that sample looking at psychosis specifically. We looked at a whole range of mental health problems, but we also wanted to get an idea of the stages of psychosis and the extent to which they're present amongst people coming into custody in New South Wales. So we had questions and we used the CALMS for at-risk mental state. So we found that just under 40% of people coming into custody in New South Wales in our study were somewhere on the spectrum for psychosis. So almost a quarter were identifiable as potentially at high risk of psychosis. 5% were experiencing a first episode of psychosis, and 10% had a diagnosis of psychosis that was established. So yes, right across the spectrum, very high rates, particularly on entry into prison. And since that screening study, we have used the findings from the research to update the approach to screening across prisons in New South Wales. And so we now have data from the use of this new tool, the prison mental health screening tool, which was implemented in New South Wales in 2021. And this shows you the rates of self-reported mental health problems amongst everyone coming into custody for a full year. So we had almost 11,000 separate screens completed in that sample. And of course, we're now avoiding some of the biases of studies where patients and people are recruited, because of course, if you're very psychotic, you're actually likely not to be capable of consenting to research. And so we actually miss some of the most unwell people from those studies. So this includes everyone, 99.9% of people, some kind of screening is done when they come into custody. And in this study, we found that 10% reported psychotic symptoms recently, 14% a history of schizophrenia, 7% a history of drug-induced psychosis. So in those really high rates confirmed for the whole population. And we can see now in this more recent sample, the proportion of First Nations people amongst those coming into custody has risen to around a third of men. And this is too detailed a slide for you to read, but I just wanted to make this point about differences between men and women. We obviously see much larger numbers of men than women in custody. Somewhere in the region of 85 to 90% of people in prison are male. But the women that are in prison have very much higher rates of mental illness than do the men in custody, who themselves have higher rates than you'd see in the community. But these blue highlighted cells are all the circumstances in which women have a higher prevalence of mental health problems than men. And actually the one exception is drug-induced psychosis, where men have a higher rates than women coming into custody. So we really need to well-resource our mental health services in women's reception prisons, given the enormously high rates of mental illness. Additionally, we also find that people who identify as having a First Nations background, being First Nations people, also have, on the whole, higher rates of mental health problems across the board. We took our screening study sample, that smaller sample that we started with, that I showed you the stages of psychosis prevalence for at screening, and we followed them up with linked data after they were released and for 12 months post-release, to look at the kinds of health contacts and then further justice contacts that people we had seen and recruited at screening had. And we see really high rates of health service, particularly emergency health service use amongst people who are released from prison. This is not a sample of people we've recruited because they have mental illness. This is a sample of people recruited just as they come into custody. But we see in this group an extraordinary statistic, I think, that within 12 months of release from prison, an unselected screening study sample are admitted to a psychiatric hospital at a rate of 10%. Difficult to think of any other group in the population who are not selected for having mental illness who would have such high rates of psychiatric admission. 1 in 5 have contact with community mental health teams. And very concerningly, more than half are back in custody at some point in that 12 months after release. And even more concerning, those with severe mental illness were actually almost twice as likely to be reincarcerated within 12 months. Thinking about this problem of people coming in for short periods and how mentally unwell that group is and how difficult it is to identify and meet their needs, we conducted a study where we specifically recruited people from reception who had mental health problems and were likely to be released within a short period. And this is just to confirm for you that even higher rates of vulnerability, mental health need, and post-release health service contact in this group. So this is the referrals on release. So 12.9% of our group that we identified were referred to a mental health service on release. And those with serious mental illness were more likely to be referred, as you'd hope. Some had prior community mental health contact, and many reported psychotic symptoms on screening. But then after release, during that 12 months after release, we see that twice the psychiatric admission rate in this group. So 1 in 5 of this group we could identify as they came into custody were admitted to a psychiatric hospital at some point in the 12 months. It's an enormous rate. And now this group are being reincarcerated at an even higher rate than that we previously found. 60% were back in custody. So just perhaps to take a moment to summarise some of those findings and key take-home messages for you, particularly focusing on this prison and psychosis phenomenon. While the burden is well known, well established, you saw that systematic review back in 2012, which already had over 100 samples internationally. This has been really well studied. I think what I would like people to think about is that our research to date suggests that the true extent of the burden, while it varies across jurisdictions and over time, it actually might be greater, particularly amongst those coming into custody, than previously estimated. That there's some evidence that the prevalence of mental illness, is particularly psychosis amongst people in prison, is actually increasing over time. We do see a peak in the burden of mental health problems at prison entry, which we've talked about, and also that some groups have even higher rates of mental illness, particularly women and First Nations people. And finally, that on leaving prison, we see really high rates of particularly emergency mental health service contacts. So that's calling ambulances, turning up to emergency departments, being admitted to psychiatric hospitals, as well as very high rates of repeat justice contact. I wanted to just mention something about this really complex issue, which is a long talk in itself. Is I've tried to convince you, I think, that it's really well established that people with mental illness, including severe mental illnesses like psychosis, do have an increased risk of contact with the justice system. But the bigger question is why and what can we do about it? There are a lot of factors. It's a complex relationship between psychosis and risk of violence, risk of crime, risk of justice contact. There are a number of confounding factors that are really important to think about: substance use, socioeconomic disadvantage, and there are factors that probably mediate the relationship more directly. So the effect that psychosis can have on people's cognition, their ability to think clearly, on their social circumstances, on their levels of impulsivity, and in particular, the extent to which psychotic symptoms can have an impact on affect. There's quite a bit of interesting research suggesting that It may not be the experience of common psychotic symptoms per se, but if those common psychotic symptoms, so persecutory delusions, for example, are also occurring or have the effect of disturbing affect, so making someone very frightened or very angry, then the salience of those symptoms and the affective disturbance caused can drive offending behaviour, including violence. It's also worth thinking about the broader life course when wondering about what's underlying this association. So we know there are sources of early life vulnerability that give rise both to an increased risk of later psychosis and an increased risk of later violent behaviour, offending and justice contact. And those early life factors are both genetic and environmental. And it may be that that early life vulnerability, the onset of psychosis itself, then has a further impact on risk of violence. So I just wanted to kind of highlight there is thinking around this in the literature, but it's not going to be my focus today. I'm happy to answer questions about it, but in the interest of time, just wanted to move on to some of the other topics that I was keen to cover in the short time we have. So firstly, to say something a bit more about men and women. We've talked a little bit already, and I wanted to just let you know that there's fairly now consistent evidence that while men are most common perpetrators of violence in society, that amongst people with mental illness, the gap between men and women narrows. So there's a narrowing of the gender gap, as it's called, so that, amongst mentally ill samples, you find that women have a much higher relative rate. And I guess this is in part because ordinarily women's risk of violence and contact with the justice system is very low. So whatever it is that protects them, likely biopsychosocial factors, a whole complex array of factors that protects them from violent offending and justice contact, is really eroded by the presence of mental illness, including severe mental illness. And this is just going back to that systematic review again, where I alluded to the fact that the strength of the association between psychosis and violence is greater for women, almost twice the strength of the association than for men. Temporal issues are really important. So as all of you would know, psychosis can be a chronic mental health condition, can vary over time during the course of someone's life. And where violence or offending or justice contact tends to occur in relation to that life course of experience of psychosis can vary. And one way of thinking about the kinds of patient groups that experience psychosis and justice contact is to think about these temporal relationships. So there has been this description of two types, type 1 and 2, mentally ill people who have justice contact. One group, the type 1 group, the much bigger group, who have tended to have contact with the justice system and antisocial behaviour from early life, predating the onset of psychosis. And then there's a second group whose violence appears to be more directly driven by their psychosis. They have had no or little contact with the justice system, no prior offending until adulthood following the onset of a psychotic illness, and they tend to be described as type 2 offenders. And we see the more serious violent offences amongst this group. So homicide, for example, is more common in this group. And that makes you wonder about first episode psychosis. There's some research which comes from New South Wales. It's now quite old, but Matthew Large and Olive Nielsen were really interested in this issue of violence and justice contact in relation to first episode psychosis. And I showed you in our screening study that we see really high rates of at-risk mental states, and first episode 5% of people coming in through screening were in a first episode of psychosis. And there are lots of reasons why you might think that that period of a psychotic trajectory is particularly high risk. So that's worth thinking about. So what can we do about it? Ultimately, as clinicians and as researchers thinking about these issues, we're really interested in what can we do to reduce the risk and what can we do to reduce the likelihood of people having contact with the justice system. These are really terrible outcomes for people and for victims involved. But there's actually not a lot of great research focused on answering this question. There have been studies that have included violence and justice as an outcome, but it hasn't been their primary outcome of interest. So the UK 700 study, now quite an old study, which was an RCT of intensive case management in the community for psychosis, found no impact on violence risk. Some pharmacological studies have looked at violence and see some differences between different agents. Clozapine, for example, has been repeatedly found to be associated with reduced rates of aggression and violence. The NSAC study, which is a study focused on substance use, but does look at other mental ill health, and did find some relationship between community treatment, continued community treatment, and reduced risk of violence. We're still really at the stage of not being clear about whether it's enough to treat people well for their psychosis, and if their psychosis improves, that's sufficient to reduce the risk. It may be that there needs to be more targeted intervention, either to the criminogenic factors that can influence justice contact and violence risk, or to targeted to those who are at the outset of presenting with increased risk. We did a study using making use of RCT data for the OPUS study, which is an early psychosis RCT conducted in Denmark. And this was an intensive case management type intervention for first episode psychosis. It was an RCT compared to standard CMHT care. The study did find that clinical outcomes were improved, so it was better treatment for psychosis and other outcomes, but it had no effect on offending, at least in terms of justice contact. So we relied on official criminal records for this data, and we didn't find any relationship at all. We do, however, and this is local, more recent data, find that those who are identified as having mental health problems at court, at magistrates' court, so they've committed lower level offences and found to have mental illness, that if they're diverted away from the justice system, that their rates of reoffending are reduced. We find this consistently. It's true for men, it's true for women, it's true for different types of diversion, true for First Nations people, true for young people in New South Wales. We've studied all of these different subgroups, and we find diversion to be associated with reduced reoffending in all these circumstances. And there really is not much in the literature that is associated with a reduction in reoffending. So it's a really important finding. We haven't got loads of time, but I did want to just mention to you a bit about forensic patients. And I mentioned at the beginning, they are a subgroup of people with severe mental illness, typically psychosis, who have committed serious violent offences, and the court has found either that they're unfit to plead because their illness is so significant, or because at the time of the serious violent offence, they were so affected by their severe mental illness that they were not fully criminally responsible for that act. We've been studying this group. They're the group that you find in the forensic hospital and in medium secure units in New South Wales. And we've studied this cohort, linking them to statewide health and justice records. And I think in the interest of time, I won't go into detail other than to say that one of the things we've looked at is reoffending rates after release from secure care. So typically after release from medium secure care, and we find lower rates than you would find in a prison population released. 12 months post-incarceration reoffending in New South Wales is around 40%. I mean, you saw in our samples that 50% of people that we identified from screening were back in prison at some point within 12 months. So rates are very high. For the forensic patient group, we found 6.3% overall rates of reoffending, so much lower. We also looked specifically at First Nations people who were forensic patients. We had funding from the New South Wales Mental Health Commission to do this. I worked on this project with Dr. Liz McIntyre, so I'd like to acknowledge her. She's an Aboriginal elder and independent academic. We did both quantitative and qualitative work, and I'm really, in the interest of time, don't have time to show you the details of that, other than to say what we did find overall was increased levels of complexity, vulnerability and need amongst First Nations forensic patients and poorer outcomes. So we did find that following release from secure care, First Nations forensic patients were more likely to be charged with an offence, and their first offence occurred at a shorter time after release. So the conclusions of this report were really around the need to better address the needs, including the cultural needs of this group, that our current forensic mental health services are not doing as good a job with First Nations people. And then in the last few minutes, I did want to just talk a little bit about whether or not people with mental illness, such as psychosis, are actually also at increased risk of being victims of crime and violence, and not only of offending or perpetrating crime and violence. And I've done some work with Danish colleagues on this question. They have these fantastic data sets based on police records where victimisation is recorded. And we added to the literature really because there's very much less done on this question than there is on the association between psychosis and risk of violence and offending. The few studies that had been done did show an association, and we confirmed that. So we found that those with mental illness had over twice the rate of violent victimisation, almost 3 times the rate for women. So again, we see higher relative rates for women. The relative rates were increased again, just like it is the case for violence perpetration across all diagnostic groups. And in addition to the psychoses, the other diagnoses that are really important are substance use problems and personality disorder. We did a review as well, looking at studies prior to this study, where we finally wanted to look at both outcomes, both perpetration and victimisation, in the same large population-based sample, and we were the first to do this. And I'm not going to obviously go into the detail of the results, but the take-home messages are that sometimes you're asked this question. I think as clinicians, sometimes we're asked this question: are people with mental illness at greater risk of being victims than they are of being perpetrators of violence? And so we looked specifically at that question. It's actually not been asked in, we found only 3 previous studies that have asked that question specifically. And really the answer we found was it's complicated. It's clear that risks of both outcomes are increased for people with mental illness. Whether one risk is greater than the other depends on how you're measuring risk, whether you look at absolute or relative rates, whether you're looking at men and women. So we found probably the answer to that question: are people with mental illness at greater risk of being victims than perpetrators? The answer is yes for women and no for men, is what we found in our study. The type and method of measurement of the outcomes is really important. So self-report studies tend to suggest the victimisation rates are higher than we see when we look at official records. And there is some variation by diagnostic groups. But of course, finally, the more important question is, why are the risks so high, and what can be done to reduce them? And that's the end of my presentation. Thanks very much for listening, and perhaps we'll have some time for questions.
We sure will have time for questions, Kimberlie. Thank you so much for that wonderful presentation. You've given a really I think, fantastic overview of what are very sobering statistics around what mental health looks like in forensic settings. I thought I knew how bad the situation was, but I think hearing those stats today really, like, kind of, I was like, whoa, that's even worse than I thought it was. Really scary. We've had a few questions come in, which is fantastic. I might just start off with one of my own, if that's okay.
Of course.
I was just one of your studies indicated that around 40% of people coming into forensic settings were at some stage on the of the psychosis spectrum. On entry to prison, including at risk mental states. I imagine that that's going to indicate that we, as that a lot of these people have not had contact with mental health services at all at any stage, and it led me to think: are we potentially missing, or is the justice system missing a lot of potential Section 14 or Section 33 applications, which would have those charges dismissed on mental health grounds?
Yeah, so that study is the screening study where we took a sample of people as they came in or just after they came into prison. And so some of them would go on to be diverted. So you can, come into prison initially, then when you go back to court for your matter, if it's a non-indictable offence, and you're deemed eligible for diversion, the magistrate can divert you at that point. So we would see some of those people in that sample potentially diverted. And as I mentioned in the studies we've done on diversion, we do see good outcomes in terms of reduced contact with the justice system subsequently. But I think the research does suggest this group are not always being picked up through other mechanisms. And for a reasonable proportion, contact with the justice system and screening is the first time that psychotic symptoms have been identified by a service. So I think there are real opportunities given we do this routine screening in a highly vulnerable group, there are real opportunities to do better in terms of identifying and then making sure people are getting the help that they need. But it's a very complex group in a complex context, and we all know the state of services and how difficult it is to meet the demands of people who are just, turning up in A&E departments, let alone people we're trying to additionally find. But certainly there's a lot of unmet need out there.
Thank you for that. I think that does clarify the way that I was thinking about the situation too. And I think, I know that you had more slides but didn't have time to touch on it, but the complex nature of the psychosocial situation of people that do experience psychosis. I've got a couple more questions here, Kimberlie. One was specifically related to First Nations Australians who are really overrepresented, especially those that do experience mental illnesses such as psychosis. And in your opinion, what sorts of specialised support is needed in the prison system for First Nations people in order to kind of improve that continuity? Are there things that need to be specific around things delivered by Aboriginal practitioners and organisations that might help outcomes in the longer term?
Yeah, as you can imagine, it's not an easy, quick answer, and there are so many elements that need to be thought about. From the whole journey someone might have in mental health systems, and earlier in life, as well as the experiences they have in contact with the justice system. But one of the things we have consistently found in our research is that First Nations people experience increased barriers to accessing healthcare, services through that they need in the justice system. And there's a whole host of potential reasons for that, but that's really crucial to address. So what we find in our studies of court diversion, for example, is that First Nations people who are found eligible by clinicians, who make it to see the clinicians and are assessed as being eligible for diversion, are actually less likely to be diverted by magistrates than non-First Nations people. So even at that point, we were in effect, that leads to an increase in the relative incarceration rate for First Nations people. So those barriers we really need to address. We see the same thing in the forensic patient part of the service. So we've been doing quite a lot of work co-designing and working alongside First Nations people to think about how to address some of these barriers, increasing the number of staff who are Aboriginal in key positions is one of the strategies, and that's really changed in an even relatively short time in Justice Health, in the justice system. We've had a real increase in funding for Aboriginal identified health and peer worker positions. So I think that kind of thing is really important. Retaining key connections to community, to family carers, but also to organisations, and managing that post-release period is also really key. We're doing a study at the moment funded by the MRFF focused on First Nations people with mental illness and supporting transition back to the community. And that is one of the really key areas that we need to do better is that connection.
Yeah, no, fantastic. I think that there's some really, sounds like there's some sensible places to start there, and really heartening to hear that you're doing research in this area, which I'm sure will ultimately help change systems and improve outcomes for these populations. I think we've got time to squeeze in one more quick question, and that is around your comments around the forensic mental health system. Yes. Having people that go through that system have significantly lower rates of reoffending compared to those in the main system. And just about, do you have any understanding of why that might be the case?
Well, I think that's a really interesting and an important question, and I don't think we do entirely understand. So obviously one of the obvious answers that comes to mind is that for the forensic patient group, their offending was to a large extent, we assume, driven by their mental illness and unmet mental health needs. So by addressing those in the forensic mental health system, we should therefore be reducing their risk of reoffending and repeat justice contact. Although I did show you in the studies, the limited studies we have to date on treatment, that's not such a straightforward answer. I personally think one of the key aspects of what happens in the forensic mental health system that doesn't happen to the same extent in custody is that we have a very careful approach and a stepwise approach to the return to community after detention. So we start with escorted leave, we trial that for periods of time, we then extend it, each step with testing to see to what extent the patient's able to manage, then the risks are managed, and not progressing to the next step until we're confident about that, so that by the time people get to the community and they're still under careful monitoring and supervision with conditions, they're actually really well and well managed. Whereas you obviously see quite a bit people released from custody who are in detention one day, out of detention in the community the next day, with very little in the way of support and supervision. So I think that part of the model of care in forensic mental health system is probably one of the key reasons.
Yeah, no, thank you, Kimberlie. I think that I know personally I can't speak for everyone else, but really to have your expertise in this area and being able to share it with us has been really enlightening and, as I say, quite sobering and an eye-opener for me. And please keep up the good work in this important area. Virtually, I think if everyone can thank Kimberlie, although you probably won't see Kimberlie because of the nature of the call that we're on, but lots of positive things going on there. So what we'll do is we'll draw today's webinar to a close. Thank you once again. Thanks again. We've got our next Mindgardens TRSP webinar, which will be on the 14th of May. And there's also a little QR code on the screen now that will take you to the Mindgardens events page, where you can see all upcoming activities and courses that Mindgardens are hosting. Thank you once again, everyone, for attending, and look forward to seeing you next time.
Thanks, Andrew.
Thanks, Kimberlie.